Tēnā koutou katoa. Welcome to those who have wisely decided to join us for this evening's webinar with Kathryn Lee. Kathryn has been working for Auckland District Health Board in the ophthalmology department for just shy of 20 years, not one or two. Recently a nurse practitioner in ophthalmology after working predominantly as a clinical nurse specialist for over 10 years. Safe to assume she has a wealth of knowledge to share with us. Her role is diverse and includes assessment and management of patients with acute ophthalmic conditions, as well as running nurse-led clinics. I highly suspect you're eagerly awaiting Kathryn to share her clinical knowledge on this interesting subject, and so I'll now hand you over to Kathryn. Thank you.
Great, thank you. I'll get straight into it because there's actually a lot to cover. I was asked to talk about common eye conditions and then include around assessment and examination of the eye. So I'm probably not going to cover everything. Hopefully there's something there for everybody. Just depends what area you work in and how, but hopefully there'll be some useful information. Just also at the end, I do have a lot of slides with some resources in case that you're not familiar with them. I don't know if you want to take a screenshot or a photo of those slides. Otherwise, my email address is at the end. So if I'm happy if anyone wants to email me, and I can send out a PDF of the talk if you like, or any other information. And as I say, we're not going to really cover everything, but happy to expand on anything, you know, at a future date if needed. So, oops, let me get my thing working. So just going to do just a very basic reminder about anatomy and physiology of the eye, and then we'll look at the assessment, so history taking, important tests, physical examination of the eye, some red flags of common presentations, some other common eye conditions, and then the resources. So hopefully we'll get through everything. Just very basically, I guess, to point out that it's important to remember, of course, we have this, hopefully you can see my cursor on there, this the bony orbit or the eye socket, and then within that we have the globe or the eyeball, which is basically, in simple terms, made up of 3 layers. So there's the sclera and cornea, which make up the outside protective layer. Then the choroid, which is the iris, ciliary body, and then the vascular layer that runs around underneath the retina. And that's the part that gives us out the red reflex and used to give us red eye on cameras, but we don't seem to see that so much anymore. And then, of course, the retina, the neural layer, lines the insides or 2/3 of the globe. There's also 6 extraocular muscles, 6 cranial nerves, the conjunctiva that lines the lids, and of course our eyelids and lashes. And it's just important to remember all those structures play a really important role in the function of the eye. So we need to consider, you know, all those aspects when we're looking at the eye. And of course we're all familiar with the refraction of light, so that comes through the cornea, does about 70% of the refraction. The image goes through the pupil, the lens does some more of the refracting, and then hopefully that is focused on your macula here, which is our central vision. In terms of assessment, just going to have a quick look at some history taking, and I don't want to be teaching people to suck eggs. This is, you know, I'm sure you do this same every day, but sometimes with the eye I think it's not as familiar. But the principles are basically the same. So symptoms commonly are vision loss, pain, photophobia and discharge, you know, the more common presentations. And it's important just to sort of clarify, is that a sudden or gradual change? Is it just a bit of a blur, or is it really a marked change? In terms of pain, you know, the degree of pain and also the type of pain. So a gritty foreign body sensation is often an ocular surface problem and generally a fairly minor issue, whereas an ache or significant photophobia can indicate something a bit more serious. And discharge, again, the type of discharge, is it watery, mucoid, purulent, sticky, and I'll talk a little bit more about that later. And is it worse at certain times of day? So conditions such as blepharitis is often worse when people wake up in the morning, and other dry eye conditions may get worse as the day goes on. So that's quite relevant information as well. And of course, again, like anything else, duration of symptoms, when was the onset, the length of time. Often we get referrals, reduced vision, but there's no time frame, and it does help with triaging referrals. Again, is it sudden or gradual? Is it constant? Is it intermittent? One or both eyes, or sequential? So conditions, say like viral conjunctivitis, really typically will present in one eye, and then a couple of days later will present in the other eye. Relieving or exacerbating factors and exposure to chemicals or other irritants, or even eye drops. And that's quite an important thing to remember, because some eye drops can cause an eye to be red. People can develop an allergy or a sensitivity to eye drops. A lot of glaucoma drops people will use for long term for years, and then they'll develop a sensitivity to it. Decongestant eye drops such as clear eyes, and people often use those chronically, and they can get a rebound inflammation, so they actually make things a bit worse for themselves. And of course, polypharmacy is always a bit of an issue. So, you get some drops from the pharmacy and some drops from the GP, and then some drops from your neighbour's auntie, and sometimes that can actually cause a lot of irritation and inflammation in the eye as well. Important to check about previous eye problems, because a history of trauma or previous eye surgery, even years down the track, patients can develop secondary glaucoma, they can develop cataracts earlier, they can have a retinal detachment. So it's important to get that information. And of course, contact lens wear, particularly in a patient with a red eye or vision loss, is really important history to note as well. Always have a low suspicion for any risk of a penetrating eye injury, so particularly trauma from a pointed object or a projectile, even really small, can cause a penetrating injury. And just like with any, I'm sure many other presentations, patients will often attribute their symptoms to something quite coincidental. I mean, we all do it. I was like, oh, my elbow's a bit sore. It must have been when I was moving that furniture yesterday. But we're trying to justify a reason, and that often happens. So it's important, if things don't really fit with what the patient's saying, to just really look for another cause. Medical history is really important. So recent cold or flu type symptoms often points to a viral conjunctivitis. Autoimmune conditions, we're thinking about uveitis, scleritis, episcleritis, those sort of ocular inflammatory conditions. A lot of systemic medications can cause eye problems as well. And also just noting age. So for example, children are unlikely to get symptomatic acute uveitis, and children won't get giant cell arteritis. And likewise, elderly people often don't have an autoimmune related uveitis, for example. You'd be thinking more like a viral cause. So, different conditions will, more prevalent in different age groups. So just looking at the assessment, so just going to go through each of these really quickly. Always check visual acuity, even if patients don't present complaining of vision. We do get a lot of sort of feedback that, well, if it's not a referral for cataract, we don't really need to test the vision. But personally, I think this, you're still doing an assessment of the eye, and part of that is the visual acuity. And patients don't always notice, particularly cataracts and refractive changes is gradual, and they often don't notice. And I did have a patient recently for cataract assessment who'd actually gone to the GP with an itchy, gritty eye and hadn't noticed any vision loss. GP checked the vision. She couldn't even read the chart. It was count fingers vision in one eye. And when the GP looked, she had quite a dense cataract. So hence the referral, which could have been delayed if that wasn't done. Of course, the other side of that is sometimes patients don't know notice the loss of vision, and when we test their vision, there's always a bit of a panic that this was a sudden change, but of course it's, it's just been discovered that they had this reduced vision. And patients' perception, and again, this is, across the board on a lot of conditions, their perception of the vision loss may be inconsistent. So sometimes people, no, haven't had any problem with my vision. And then you test it, and like the lady with the cataract, she's had very poor vision. Likewise, sometimes people will say, oh, I just can't see anything, it's so terrible. And you test their vision and it's 6/12 or 6/9. So it is important to still actually test the vision. And just recording any anomalies. So sometimes people with a squint, for example, might tilt their head to compensate for that. And people with macular problems may try and use their peripheral vision and not look directly at the chart. This was just from a recent study in Dunedin a year or so ago. But it is quite a common presentation, in the community to have vision issues. And of course, there's medico-legal implications, so suitability for cataract surgery, which I'll talk about a bit later, and fitness to drive. And we've had a lot of referrals. People wait about 4 months to be seen in the department, and the vision wasn't actually tested when they were referred, and they're not legal to drive. And so they've been driving around actually with inadequate vision to do that. So again, it is really important to be assessing that. The study that was done in Dunedin a year or so ago, it was a very small group, but one thing that they were comparing ophthalmology visual acuity testing with community visual acuity testing, and the most common error was that the chart wasn't the correct distance, or the patient wasn't the correct distance from the chart, and also that the lighting wasn't appropriate. So just to remember not to probably laminate vision charts, because you'll get a lot of reflection off it. And just looking at, windows around where you're testing vision. There's some quite good resources on this link to the NZTA in terms of medical fitness to drive. And if you have access to the ISO standards, there's quite good detail in there. I think that is quite hard to access that though. I'm sure you're all familiar with the vision chart. This one's just a note to make sure this is actually a 4-meter chart, but it does have the 6-meter equivalent readings down this side. So it's just important to check that, that the distance that you've set it up is correct. Sure, I'm all familiar with this too, is when we're measuring the visual acuity, we're measuring the distance vision and central vision. So if patients wear glasses for reading, so for seeing small print and things, you don't want to test their vision with those glasses. Always check though if patients normally wear glasses or contact lenses for distance correction, and you should always check the visual acuity with that correction. Now, some of you may be familiar with using the pinhole. It's really important if any vision is less than 6/9 to also test the vision using the pinhole. That's actually a link for the Snellen chart. But the pinhole can indicate a refractive error, which is just, again, useful for triaging patients appropriately. There's quite a number of, I used to work in general practice actually, and I remember these ones being around in all the drawers, but I didn't have any idea what they were at the time. So basically the principle is, instead of all this light being refracted into the eye and maybe not focusing on the macula, with using the pinhole, we just get these straight light rays that go directly to the macula. So we know that if the vision improves, there's something in front of the macula that's interfering with it. So it could be corneal changes, it could be lens changes such as cataract, and it could be some inflammation in the aqueous humor or in the vitreous of the eye as well. Oops, sorry. Another one I'm sure that you're all familiar with, but testing the red reflex. So particularly in a young child, this could be congenital cataract, it could be a squint, could be retinoblastoma. So important to check that. And again, people used to pick this up on photos with the absence of the red eye. which we're not seeing as much, of course. And again, so in an adult, I mean, this is quite a dense cataract, and of course, you're not really going to be able to get a good red reflex. Pupil assessment, looking at the size and shape. This, you may actually need to lift the eyelid. So in this example, because often the eyelid will sit lower and you may not see the top of the pupil until you lift that up. This is quite a typical irregular pupil in a chronic uveitis or recurrent uveitis. And also comparing the pupil between the two eyes. And now it might be easy to think that the abnormal pupil is the big one, but sometimes it's actually the smaller pupil that is checking your direct and consensual reaction to light is really important. This link is a really good video of doing the swinging light test, which I've just briefly got a little image here. So when we shine a light into one eye, we should get the direct response, and then the consensual response. So the other eye should respond in the same manner. And when we swing the light between the two eyes, if there's a difference, so in this one it's the pupil slightly dilated, we know that the signal from that light is not getting through on this eye for some reason. So it is a good test to try and do as well. But as I say, that link shows a very good video about it. Extraocular eye movement. So you get the patient to sit opposite you, keep their head still, and just follow a target in those 9 directions of gaze. And you may again need to lift the eyelids to just assess the inferior gazes there. And basically we're just looking for any abnormalities, so where the eyes aren't moving together. And they may be fine in one direction and in other directions, depending on what the cause is of that. Colour vision, and I'm sure out in the community you don't have expensive Ishihara plates, but we can do quite a gross colour assessment with either, a red top of an eye drop bottle, or even marker pens with a nice dense red colour there, because that's the most sensitive colour for assessing in terms of optic nerve function. Basically, you want to check each eye separately and ask the patient how much, if the redness is the same intensity between the two eyes. And some people will describe it, well, it's a bit orange in that eye, or it's a bit pink. And another useful way to just record that is if one eye looks, that's really red, that one looks, a bit paler. Say if this is 100% red or $100 worth of red, and how much is this one? And ask the patient to sort of gauge the difference between the two. Visual fields to confrontation, and this is another really important one, because patients, again, I had a patient who swore, no, it was just this right periphery that she couldn't see, it was just her right eye, and she was referred in query retinal detachment. But when I tested her visual fields to confrontation, she had a homonymous quadrantinopia. So I referred her for stroke assessment, and she had a stroke. So it is important to really check that. Now, I don't want to bag this lady too much. I don't know if anyone's watched. She does some really good nursing assessment videos online. The only thing with this is you should be sitting at the same height as the patient, because the idea is that you put your hand, your target, equidistance between you and the patient, and it should be visible to you in your visual field. So this, if she's got this hand down too low, might actually be out of his peripheral vision. So you're not really getting a good idea of the visual field there. The other way to do it is to bring a target in from the outside and the patient tell you when they can see it. However, in this one, I think a cotton bud is probably a bit smaller target. The red top bottles are again, the marker is quite a good way of doing that. But really, this is the simplest form, and it does give us just a reasonable gross assessment of visual fields. So sitting opposite the patient at about the same height, and you just imagine, so we're testing this eye, and these are the 4 quadrants that we're checking, and you put a different number of fingers in each quadrant. You can even check different quadrants twice, and just to record. And you literally can just write that, just draw a cross like that, and count fingers in each quadrant, or absent if that wasn't, if they're not able to see that one. So just going to look at external examination of the eye and some of the red flags, and I've just broken it up into the red eye, vision loss, and then some other common conditions as well. So red flags for the red eye is reduced vision on the Snellen chart, and again, as I said before, important to actually test the vision, not just rely on the patient's description of it. Severe pain, really marked redness, any abnormal cornea, and we'll look a bit more at that. Aching, constant pain, really significant photophobia, contact lens wear, and chemical injuries or potential penetrating injuries. So any of those, along with a red eye, should be your big red flags that you'd be looking at. And there are loads of causes of red eye. A lot of them are just very simple things that aren't vision threatening. Bilateral red eye conditions generally aren't too much of a concern, but it's looking at the other issues around it as well. So sight-threatening causes of a red eye will almost always present with reduced vision. So if someone has a red eye and normal vision, it's really unlikely to be anything of real immediate concern. And most patients with red eyes, as I say, have relatively minor problems. Just looking at sort of the other, as I say, the other things associated with that. So a patient who has pain in the eye, but the eye is white, the pupil's normal, and the cornea is clear, is unlikely again to be anything too worrying. HZO, so ophthalmic shingles, without any ocular symptoms is not such a concern. Simple corneal abrasions, and I'll talk a little bit more about that lately, hopefully, if we get through that. And again, viral conjunctivitis, we do get a lot of referrals for viral conjunctivitis, but if there's no loss of vision or severe swelling, again, that shouldn't be too much of a concern. It's just like any, a viral cold, that it has to run its course. But if there is significant loss of vision or swelling, they may need a topical steroid treatment, so would need an ophthalmic review. Just a little chart there with some of those red flags again. And looking at the redness again, just important to think about where it is. So is it predominantly in the lid? We'd be thinking more about a conjunctivitis, blepharitis, something like that, when the actual globe is white. Sometimes there's a little bit of a mix. And then sometimes the redness is predominantly on the globe. So you'd be thinking about a uveitis or a scleritis, that sort of thing. So just looking at where the redness is. Just a reminder that the conjunctiva, so we have the palpable conjunctiva that lines inside the lid, folds back on itself, and then the bulbal conjunctiva lines the front portion of the sclera. So you can reassure your contact lens patients that they're not going to lose their contact lens off in the back of their eye, because it can't go beyond this fold in the conjunctiva. Is the redness diffuse or sectoral? So I'm sure you've all seen a subconj hemorrhage. It's quite a dense area of redness that's usually quite localized, as opposed to something a bit, a bit more hyperemic and it's more diffuse. Again, this localized area of redness could point to a scleritis or episcleritis. This is a differential diagnosis of the red eye, which is quite a useful chart, and again, happy to share this. And it just shows the different aspects of visual acuity, pain, discharge, the redness, the cornea, for these different presentations. And for example, a subconjunctival hemorrhage, usually the vision's normal, don't usually have a lot of pain. It's usually only noticed when someone says, oh, your eye's red, what's happened there? That localized redness. Cornea is clear, anterior chamber is quiet, the iris and pupil should be normal. As opposed, if we go to the other end of the spectrum, acute angle closure glaucoma will have markedly reduced vision, like probably only the top letter on the Snellen chart, or not even be able to read the chart at all. Severe pain, often headache, nausea, vomiting. The eye will be really watering a lot, often marked injection in the conjunctiva, particularly around the corneal area. Whoops, sorry. Cornea is usually quite cloudy. Anterior chamber will be shallow or flat. Maybe difficult to actually make out the iris detail, and I'll talk a bit more about this condition shortly. But and the pupils generally semi-dilated and fixed, and not really reactive to light, or maybe just a minimal reaction. So this is quite a good way of just considering, what your options are, looking at all the different findings. Other associated findings, eyelid abnormalities. So is there a cyst in the lid? There may be a rash. There's a pretty classic HZO. Lid abnormalities that may be causing a lot of symptoms. And also looking at, lashes sometimes when they're misdirected can cause a lot of ocular irritation and inflammation and discharge as well. And speaking of discharge, of course, this type of yellow discharge is often more indicative of bacterial infection. A watery discharge is often more a viral presentation, and of course this mucopurulent discharge, you'd be thinking about gonorrhea, syphilis, chlamydia, that type of presentation. Conjunctival abnormalities, so this is some follicles. Often you see that in viral infections. That's the one that looks like little grains of rice under the conjunctiva. Or papillae, which often don't look quite as bad as that. They're often a bit finer. But in significant vernal keratoconjunctivitis, you'll see this, and also in contact lens, where sometimes when people have a reaction to the contact lens, may see little bumps on the surface of the eye. So this is a little pinguiculum, which are very common, but they can get inflamed, particularly if the eye is dry. And chemosis, so we're looking at this, significant swelling here of the conjunctiva, and sometimes that could be so bad that people can't even close their eye. Corneal abnormalities, so good old pterygium there, and the wing-like presentation, which can start to grow over the cornea and affect the visual acuity. Staining this with fluorescein looks like a pretty classic herpes simplex virus, or sometimes it can be pseudodendritic in an HZO, or the shingles cases. I haven't gone into talking about the slit lamp because it's in the community that often not available, or if you're not using them frequently enough to examine, to feel comfortable examining eyes, that may not be quite so helpful. But you may see this opacity in the cornea, and the basically if it's obscuring the iris, then you know that it's something either in the anterior chamber or on the cornea. And again, this opacity, it's really obscuring a lot of that detail there. And again, in this, sometimes there's no focal opacity, but there might be generalized inflammation. And anterior chamber abnormality. So again, without the aid of a slit lamp, it can be difficult to actually assess the anterior chamber. But again, you can see these changes are obscuring the iris detail. So we know it's the cornea or the anterior chamber. So this is a hypopion, white cells collecting in the anterior chamber, and that's sign of significant inflammation or infection in the eye. And this is a hyphema, so red blood cells in the anterior chamber. Generally, this is a result of trauma. Very occasionally, patients do have a spontaneous hyphema, but that's quite rare. And again, you may just see some clouding there that makes the iris detail difficult to view, or the pupil detail, which is really important there as well. and pupil abnormalities. So this is a bit of a classic picture of the acute angle closure. You can see the light shining in the eye, but the pupils is still slightly dilated and it's a bit oval, not really reacting properly. And again, our irregular pupil, judging by this redness on the eye, is possibly an active uveitis. Just another point here is with the light reflection, you can see that this one is nice and crisp, it's well circumscribed, but whereas this one is quite diffuse and scattered. And that's also a good indication of corneal edema. So in these cases of angle closure and sometimes in uveitis or other keratitis presentations. Just quickly going into vision loss. So there's just some red flags there. Basically, it's any sudden profound vision loss that's happened just recently, visual field defects in both eyes. And of course, in patients sort of over 50 with central vision loss or distortion, we're going to be thinking about macular changes and other retinal pathology. Transient monocular vision loss, so that could be presentation of a TIA, but it can also be an early manifestation of giant cell arteritis. And flashes and floaters and retinal detachment. So if it's a recent onset, then that does require review within a day or two, and I'll talk a bit more about that shortly. The patients who have significant short-sightedness, so they're quite high myopes, are at greater risk if they have flashes and floaters, because a myopic eye is slightly longer than normal. So as just general aging changes happen, there's more traction on the retina, so there's a slightly higher risk of retinal detachment. And just looking at pain in terms of vision loss, so retinal artery or vein occlusions, retinal detachment, vitreous hemorrhage won't be painful, and also functional. Unfortunately, that's always a little bit difficult to work out, that one. And then painful vision loss, so that's something else to consider in the assessment there. And looking at the pattern of the vision loss, so is there sort of a central distortion? Is the central vision clear, but perhaps the periphery isn't? Is there just a blur, or actually a whole blackout of vision loss, or is it just simply that that's missing? So there's an area of vision that's missing. So as I said, sorry, we're rushing through these things really quickly, but hopefully we'll get through. So cataracts, very common. This is our bread and butter. It's basically a clouding of the lens, and it is a major cause of treatable blindness. And just to recap again, so that's our lens that sits here behind the iris and the pupil and becomes cloudy for various reasons. Of course, the most common thing is age. So as we get older, most people over the age of 60 will have some degree of cataract. And then other things can affect that. So exposure to UV light, diabetes, particularly if it's poorly controlled, cataracts often develop at a much younger age, as well as poor nutrition. Topical and systemic steroid use, particularly if it's chronic, can increase the rate of cataract development. X-rays, smoking, of course, and trauma as well. As I said before, even months after the trauma, people can start to develop the cataract a little bit quicker. And genetics, so sometimes children are born with congenital cataracts, and some people, it does seem to run in families that people will develop cataracts at a younger age, maybe in their 40s or 50s as well. The most important things are early on, the vision can be improved with glasses or contact lenses. There is a government CPAC scoring system for eligibility, and unfortunately, as I'm sure many of you know, that varies throughout the country. So unfortunately, it does sometimes depend on where you live. Cataracts can't grow back, but when we remove a cataract, we leave, basically, it's like an onion. We leave the outside skin of the onion, the capsule, to put the artificial lens in. And over time, sometimes that can cloud up. So people think that cataracts come back, but actually it's just that capsule thickening, and that can be cleared with a straightforward laser procedure as needed. And another thing that people often don't realise is that they may need reading glasses post-operatively, because the artificial lens, of course, can't change focus unless you have lots of money and you can pay for ones in private that do have some multifocal ability. So most people will have their lens corrected so that they can see in the distance, and then wear glasses to see near. Now, glaucoma is another common problem. Basically, it's a progressive optic neuropathy, and it's often referred to as the silent thief of sight, because generally people are asymptomatic in the early stages, and it's often just found at routine optometry checks. Diagnosis of glaucoma is actually made by a particular pattern in the visual field changes and in the optic nerve appearance, and then the intraocular pressure can play a part in that. There's increased risk with age. Everyone is at risk of developing glaucoma, but if you have a family history of glaucoma, you have 10 times increased risk. Glaucoma New Zealand actually recommend that everyone have an eye check, a full glaucoma assessment by the age of 45, and then every 5 years after that until you're 60, and then every 3 years after that. But that should be sooner and more frequent if you have a high history of, family history of glaucoma. And this is why we recommend routine optometry checks, because these changes can be picked up there. Generally, it's treated with ocular antihypertensive drops, and then if that doesn't control the pressure, then there are laser and surgical procedures. And of course, high intraocular pressure is a risk factor for developing glaucoma. But just to confuse everything, not all patients with glaucoma have a high pressure, so that's known as normal tension glaucoma. And not all patients with a high pressure have glaucoma. So that's what we refer to as ocular hypertension. Took me a long time to get my head around that. So basically, we don't know the true mechanism of glaucoma, but the pressure does seem to play a part in it, and it's about balancing the production of the aqueous inside the eye, which is made here in the ciliary body, in relation to the outflow of the aqueous. And so if we can change that balance, if the patient looks like they're developing glaucoma, and that has been found to, not necessarily, we can't reverse any changes, but we can try and stop progression, or at the very least slow progression. So it's thought that this pressure in the eye is obviously putting pressure back onto the optic nerve and causing that neuropathy. So by far the most common, 80% of all glaucoma, is what we refer to as primary open angle glaucoma, and this is particularly asymptomatic. And about 2% of people aged over 40 have glaucoma. And just like with diabetes, it's probably double that, because there's so many people who are undiagnosed. And over 80, about 10% of people have glaucoma. Now, you're probably all familiar with the term about acute angle closure glaucoma, but the terminology's changed a bit. Because as I said earlier, diagnosis of glaucoma is made based on visual field changes to the optic nerve, and then possibly around the pressure. So patients who have acute angle closure and are symptomatic of that generally don't have those changes. So hopefully we can manage the condition before they develop those glaucomatous changes. So they're referring to this now as an angle closure crisis, and it is an acute emergency. We still have had patients who are being treated for food poisoning because of vomiting and severe pain and headache, when actually they've had acute angle closure. As I said earlier, there's significant decrease in vision, significant pain, significant redness, and an abnormal pupil. And this is in about 10% of all glaucoma it presents with this. So it is fairly an uncommon problem. So always important to keep it in the back of your mind as a differential diagnosis in a red eye, but to look at those other aspects in terms of the pupil, the level of pain, and the level of vision. This is more common in the 5th and 6th decade. Slightly higher incidence in females. Hypermetropic, so that's where the eye is slightly smaller, so all the structures are a bit more condensed in there. And also hypermature cataract. So we don't want to leave cataracts too long, particularly in a smaller eye, because it could lead to patients developing this angle closure. And just to sort of try and explain that a little bit better, as I said, the ciliary body produces the aqueous humor, which comes through the pupil and then drains out this drainage angle. If there's a smaller eye where all the structures are a bit more crowded, or there's a hypermature cataract, this can actually cause a blockage between the pupil and the lens of this fluid, which builds up behind the iris and pushes the iris forward and closes off that blockage. So that's what we're sort of referring to about, these narrow angles and that drainage angle blocking. Blepharitis, very common condition and often missed even within the eye department. People, making big decisions about patients' glaucoma, but, don't always look at the eyelids and notice that they have blepharitis. And it is very common. It's basically referred to as anterior and posterior. So anterior is often associated with staphylococcal bacteria on the lids and causes inflammation around the lashes. And patients with inflammatory skin conditions like seborrheic dermatitis or rosacea often have this type of blepharitis. Posterior blepharitis refers to the meibomian gland dysfunction, and some people have a bit of a combination of both. And basically this causes the tear film quality to be very poor, and patients have dry eye symptoms. And just to confuse everyone as well, as often patients have a watery eye and they think, well, my eyes, why are you saying I've got dry eye? My eye's watering. But that's just a reflex response to the dryness on the surface of the eye and inflammation from the poor quality tear film. Unfortunately, there's no cure, but daily lid cares are really the mainstay of treatment. But they can take a few months of doing it regularly to improve the symptoms. Ocular lubricants can help as well for symptomatic relief as needed, just to replace that tear film. And I often explain to people that it's like cleaning your teeth. We can't clean our teeth for a week and not do it for a month. We have to do it regularly as a maintenance, and it's the same thing with this treatment for blepharitis. So that top picture is sort of showing the anterior blepharitis with a build-up around the lashes and crusting, and posterior there in the bottom picture. So those little white blobs there is the meibum and the meibomian glands, and you can see it's quite toothpastey. It's very thick, so when the patient blinks, that oil is not going to coat the eye and stop the eye from becoming dry. So really important to give good education around the treatment for that. Just going to hopefully go through quickly some retinal conditions. So just a reminder there, we're talking about the retina, the optic nerve, and then the fovea and the macula, which is responsible for our central vision. A lot of information around about age-related macular degeneration now. 1 in 7 people over 50 will get macular degeneration, and there's a link there to Macular Degeneration New Zealand, which has a lot of great resources for medical professionals and for public, for patients to see as well. You're probably familiar with the terms of dry and wet AMD, but as we're finding out more in the research, we're finding there's actually a big spectrum of this, going from early changes to late changes. And we're tending to use the terms a bit more inactive and active, and patients may progress along that at varying rates, and they sometimes bounce back and forwards a little bit as well. Dry AMD is the most common. That's about 90% of macular degeneration. Being over 60, unfortunately, is a risk factor, which we can't really stop. Smoking has been found to be the most important modifiable risk factor. Ethnicity is slightly higher in European ethnicity, and family history, of course, can increase that. I won't go too much into that. I've got a couple of little pictures, but basically, over the age of 50, everybody has some degree of drusen, which is these little deposits in the between the choroid and the retina around the macular area. And they're generally not too much to worry about, but it is important to protect the eyes from the sun, eat lots of leafy green vegetables, and stop smoking, of course. Often it's not symptomatic early on. So the best thing you can do for patients, age sort of 60 and over, is to give them an Amsler grid. So there's a link there to get one of those. And that they monitor each eye separately, so they check the eye separately for any distortion, and any changes they should seek review with an optometrist, or be referred to an eye department, because it's good to pick these things up early, as with a lot of conditions. So that's just showing that sort of drusen, those little deposits building up under the choroid there. And wet AMD, that's only about 10% of the cases, but this is the one that we can treat now. But unfortunately, I mean, we are doing, every day we do lists of at least about 20 injections for these patients, and this is the smallest group of the AMD patients. Generally, we used to treat with laser, but of course that causes damage and reduces the visual acuity. Now we've been using Avastin for a very long time, and also Eylea and Lucentis, but more recently Eylea, which is $2,000 a pop, and patients are having an injection every 4 to 10 weeks for the rest of their lives probably. But we now have some funding for that, so if patients don't respond to Avastin, we can apply for funding for Eylea, but it is quite strict criteria, but that is helping a lot more people as well. And this is just showing sort of more end-stage macular degeneration. You start to get these little blood vessels growing through, and then they leak and cause all sorts of issues. So you get the build-up of the fluid. So the anti-VEGF injections help to reverse that process. Diabetic retinopathy, so type 1 and 2 diabetes can get these microvascular changes in the retina. When it's early on, it's often asymptomatic and there's not visual changes. So this is why retinal screening is really important for all diabetic patients, because if we can pick up any of these early changes, and show the patient, that's one great thing about the eye, is it's an organ in the body. We can actually show the patient pictures of their retina and say, this is what's happening to your retina, and if it's happening there, it's probably happening in your kidneys and everywhere else. And often that can really help with engagement and improving diabetic control. And obviously, as that progresses, it can be very sight-threatening. A lot of vitreous hemorrhages, retinal traction, which can lead to retinal detachment. And you can see there's just a lot of this. That's the sort of early with the drusen and maybe a few little hemorrhages, progressing to this proliferative diabetic retinopathy. And all these collateral vessels are being made, but they're weak and leaky and cause more problems. Posterior vitreous detachment is another really common presentation. This is the most common reason for patients getting flashes and floaters in their vision. I mean, as I said earlier, so myopic eyes, which are longer, have a higher rate of this. And it's not usually sight-threatening, but if patients do develop new flashes and floaters, they should have that checked in case it has caused a retinal problem. So you can see there, this is just the vitreous jelly, and it's come away, and it often causes these little cobwebby floaters in the vision that float about in the jelly. Well, of course, that can lead to retinal detachment as well as other causes. And most importantly, if there's a dark shadow or curtain coming across the vision, and they may need urgent surgery, particularly if the visual acuity is good, because we want to preserve the macula. If the macular part of the retina detaches, they often have a poor visual outcome. So even if the retina is reattached, that macula often doesn't return to as a good function. And so you can see there, so the posterior vitreous detachment could cause a little tear here in the retina, and then fluid gets through and lifts off the retina. Corneal abrasions are very common as well, and they're very painful. And it's usually a fairly superficial trauma, like fingernails or the corner of paper or cardboard, leaves or twigs brushing across the eye. And it is significantly painful. And the eye will be very watery and photophobic. They may have reduced vision if it's quite a central abrasion, but generally should resolve within 48 to 72 hours. If it's not resolved after that time, then you might be more suspicious of something more significant. So generally just chloramphenicol ointment or drops to prevent infection and make the eye more comfortable. And I'll talk in a bit about putting the iPad on. This is just to demonstrate. So in that little tiny section of the cornea, this is the density of the nerves in the cornea, and they all are demyelinated as they come up to the surface. So if you brush off these epithelial cells, all these little nerve endings are exposed, and that's why it's so painful for people. And unfortunately, it really has to heal up for them to be more comfortable. So use of fluorescein is really important in these cases. And this eye, you probably can't really see, maybe that light's a bit scattered. You might be able to see this line down here, but really you can't see a lot going on until you put the fluorescein in, and they've got a massive corneal abrasion. So it is really important to have that around as well for assessing eyes after trauma. And that's the same eye 2 days later. So you can see that fluorescein has almost completely resolved. So they do generally heal up pretty quickly. There's a lot of literature about whether iPads are useful. It's a bit debatable. We tend to just go with the, if it's more comfortable with the pad on, then we'll go with that, and if not, just leave it uncovered. But then if you're going to use an iPad, really important to make sure we fold an iPad in half and then usually put another one flat over the top. You need to make sure the eye stays closed underneath the iPad so the pad doesn't rub the eye and cause more injury. Corneal foreign bodies are pretty common, but also remember to avert the lid, because you may find a little subtarsal foreign body under there that can just be wiped away with a cotton bud. Just an important point about eye drops, you know, they are a medication. They can cause some systemic side effects, and punctal occlusion can be quite useful in reducing that. So basically you're blocking off the nasolacrimal duct after putting the drops in to reduce the drop going into the nasolacrimal system there. So I'm just kind of rushing through because I'm conscious of time. Just a few notes about contact lens wearers. So red sore eye, always remove the contact lens. You wouldn't believe the amount of people who don't. They try and keep wearing them. Don't overwear contact lenses. So sometimes people have daily contact lenses and they'll wear them for a week at a time. We recommend not sleeping in contact lenses, even the extended wear ones. I'm sure it's nice to wake up and be able to see, but you are depriving the cornea of oxygen. And again, with, you know, wearing contacts in swimming pools and spa, you know, when you're swimming, obviously it's a bit hard to go in the ocean with glasses on, but people should be aware that wearing contact lenses does increase the risk of infection. And so if they were to wear them, particularly in the ocean or swimming pools, it's a good idea to take them out as soon as possible afterwards. Never use tap water or saliva to clean the contact lens or cases, and should always dry the hands before handling the contact lenses, because there is slightly increased risk of amoebas and other infections with the use of tap water. And unfortunately, people go to the markets and buy these cosmetic contact lenses, and because they think they're not real contacts, they share them with their friends. So just something else important to be aware of. Of course, prevention is better than cure. So sun protection, protective eyewear, general health factors, regular eye checks, as I said, with the optometrist, managing the blepharitis, try and prevent complications, and good contact lens and hygiene wear. So I won't really go through all of these, we haven't got a lot of time, but this is a really good free download from Sydney Eye Hospital, and it has all the presentations, you know, the history to look for, the examination, treatment and investigation, so you can download that for free. Also the Auckland Eye Manual, this is the paper version, but they have you can download to your smartphone, and they have these really good tables. So you just follow. So that's, say painless loss of vision of minutes duration, and it's unilateral. We're thinking about giant cell arteritis and amaurosis fugax, and it directs you to the page which gives you all your assessment and management guidelines. Regional health pathways. So we're on there. If you're looking for us, we're under surgical. We often get moved around because we kind of cross surgical and medical boundaries. So, and you can again look there for all the different resources, and there's lots of links and information to help there. So a bit more detailed to, and also links to doing these tests that we've sort of just gone over. And Healthpoint, don't know if a lot of you use Healthpoint. You can actually find local ophthalmologists and optometrists, which are a really good resource, particularly in smaller areas where you don't have really close access to an ophthalmology department. They can be really helpful as well. Lots of optometrists under there. BPAC guidelines, that's probably a wee bit old, 2013, but I think it's still pretty relevant. And Macular Degeneration Retina New Zealand, Blind and Low Vision New Zealand, used to be called NZ Blind Foundation, and the Association of Optometrists. So that's just some more useful resources there, hopefully. So just to quickly wrap up, so visual acuity, please try and always try with the pinhole as well if you can, as much detail as possible. High risk, chemical injuries, penetrating injuries, corneal opacity, sudden loss of vision should be referred immediately. Photographs, really important. We're getting like great photographs coming through from GPs, lid lesions, corneal lesions, conjunctival lesions. Is really helpful as well. And as I said, make friends with your local optometrist, because you'll probably get a lot of support from them as well if you can. And look, 2 minutes to spare. Hopefully there aren't loads of questions.
Oh, there's heaps of questions. You're going to be swamped, Kathryn. No, I think you've done a very good job. That was absolutely amazing. Thank you so much. Really interesting.
So it was a bit of a whirlwind.
Oh, no, it was a good pace, actually. I think you did it really, really well. Thank you. So just in terms of questions and things we've got coming through first, just to let people know that the presentation will be made available. Just they'll get a bit of editing done on it, and then it will go out to everyone who's been registered for the session. Kate is asking about a burr versus a needle. She says there seems to be some conflicting thoughts for the removal of,
for corneal foreign bodies. We tend to just use a needle, generally a 23 gauge needle. Our corneal consultants don't like the burr. They feel like it causes more damage, but it is quite effective in removing rust. But often you can persevere with a needle and remove it. So it's probably comes a bit down to personal preference. But as I say, our corneal consultants don't like the burr at all. They prefer a needle to be used.
Thank you. And then we've got Jenny. Jenny is asking if you've got any tips to put in a Morgan lens. I sometimes have trouble with them falling out.
My only tip about a Morgan lens is not to use them. They are, unfortunately, even the product information that comes with them say that after you've used the Morgan lens, you should take it out and manually irrigate the eye as well. The problem with them is that they sit on the eye like a contact lens. They can trap particulate matter underneath, and the eye is supposed to sit closed over, and again you can trap particulate matter. So we actually don't use them, and we don't support the use of them. And as I say, even their product information tells you to take it out and then manually, pull the lids down and sweep with a cotton bud and make sure that you've cleared the fornices as well. So that's probably not that helpful since you're using Morgan lenses. But the other thing is, you know, you must make sure that you instill topical anaesthetic if you are using them, because otherwise they're very uncomfortable. I've never used one myself, but I presume that you would get the patient to probably look down first and lift the top lid and put them underneath the lid, and then get them to look up and pull the bottom lid down to try and fit them in there. But as I say, we don't use them.
Oh, well, thank you, Kathryn. Well, no one else. Oh, there we go. So Kate's just saying thanks for an awesome presentation, so informative. And Tracy's also saying thank you very much, found it very interesting. There's some lovely feedback coming through there, Kathryn. And I guess just one thing I'd like to say is at the beginning of this, before everyone came on, Kathryn did say that she would be willing to do further presentations at a later date if there was other subjects that people were interested in. So if anyone has got any particular subjects they'd like looked at, they can either email through to Mobile Health or through to Rural Nurses New Zealand or onto our website, and we can try and arrange further presentations on the subject. And there's Di Williams saying ditto as well. She enjoyed your presentation too.